the video, we will be discussing about acute lymphoblastic leukemia. So to begin with, let's take each term in that. It's also in short form, it's written as ALL. Now, acute lymphoblastic leukemia, what does the term mean? Acute means the onset is acute, that the symptoms appear in an abrupt onset. Lymphoblastic means it's a neoplasm that affects the lymphoblasts. Now, what are lymphoblasts? Lymphoblasts are precursor cells of mature lymphocytes. So we could say that they are immature B cells or T cells are called as lymphoblasts. And finally, the term leukemia. Leukemia involves neoplasm that affects the bone marrow or the peripheral blood. So neoplasm that involves the bone marrow or the peripheral blood is what we call as leukemia. So that's what the term acute lymphoblastic leukemia means. Now, by definition, acute lymphoblastic leukemia is a group of neoplasm consisting of lymphoblasts. Now, we need to differentiate lymphoblasts from myeloblasts. So, myeloblasts are actually the precursor cells which are involved in AML, that is acute myeloid leukemia. So, they are involved in AML, whereas lymphoblasts are involved in ALL, that is acute lymphoblastic leukemia. Now, how do we differentiate? So, let's draw their diagram. This is a lymphoblast, and this is a myeloblast. And let's draw the nucleus of both of these cells. Now, as we can see in the figure, the lymphoblast, this is our lymphoblast, while this is our myeloblast. Now, when we compare their size, firstly, the lymphoblast is 2 to 3 times larger than a normal lymphocyte. Larger than lymphocyte, which are the mature B and T cells, whereas a myeloblast is larger than both lymphoblast and lymphocyte. It is 4 to 5 times larger. That's the first distinguishing feature. The next feature would be the amount of cytoplasm. So, myeloblast has more cytoplasm, where lymphoblast has less cytoplasm relatively. The third point will be regarding the nucleoli. So, there will be 2 to 3 nucleoli, whereas in a lymphoblast, whereas in a myeloblast, there will be 3 to 5 nucleoli. So, there are more nucleoli. That's the third feature. More nucleoli in a myeloblast compared to a lymphoblast. And the final and the most important or the distinguishing feature is the presence of ore rods. So ore rods are peroxide positive granules which are present inside the myeloblast, and they are absent in lymphoblast. So presence of ore rods is a feature of myeloblast, whereas they are absent in the lymphoblast. So these are the distinguishing features. Let's mark the ore rods here. These are our ore rods. Now let's briefly discuss about B and T cell leukemia. To understand the different types of B and T cell leukemia, let's have a figure. Here we have a figure of bone marrow, and this is a figure of thymus. So from the bone marrow, what happens is that there is a common lymphoid precursor cells are produced, which will denote as CLP. And from the common lymphoid precursors, they will develop into the B lymphoblasts, which are the precursor B cells, which then develop into non-B, which then develop into naive B cells. These naive B cells, they will enter a lymph node. So this is our lymph node, and inside the lymph node, they undergo further development. So these naive B cells or mature B cells in the lymph node, they develop first into marginal zone B cells, and then they develop into germinal center B cells. So once again, from the bone marrow, the common lymphoid precursor develops into B lymphoblast, and lymphoblast develop into naive B cells, which then move into the lymph nodes, and inside the lymph node, they develop first into marginal zone B lymphocytes and then into germinal center B lymphocytes. Now, why have we mentioned this? This is mentioned to understand the different leukemias, to know from where different leukemias originate. So before speaking about the B cell leukemias, let's first complete the development of T cells. So the T cells, they are initially, there are DN T cells. What it means is double negative T cells. That is, these T cells are negative for both CD4 and CD8. and then they develop into double positive B cells. What it means is that these B cells are positive for both CD4 and CD8 markers, and then they develop in a single positivity. That is, either they develop into CD4 positive T cells or they develop into CD8 positive T cells. These CD4 or CD8 T cells, they will then enter the lymph node, and in the lymph node they develop into the peripheral T cell. This is how the development of T cells occur. Now let's identify the leukemias, from where all they origin. Now we began with the lymphoblasts, right? These are the lymphoblasts. Now a leukemia of lymphoblast is what we call as acute B-cell lymphoma, acute lymphoblastic leukemia of B cells. What if the leukemia originates from the naive B cells? Well, if it originates from the mature naive B cells, it is called small lymphoblastic leukemia or small lymphocytic leukemia, or it's also called as the chronic lymphocytic leukemia. CLL is another term used for this. And when they originate from the germinal center, they could be Burkitt's lymphoma. It's an example. That is Burkitt's lymphoma or Hodgkin's lymphoma. Hodgkin's lymphoma. We could actually add an additional development as well to the germinal B cell, because B cells ultimately they form plasma cells, right? So they will form plasma cells, and if the tumor originates from these plasma cells, it could be multiple myeloma, which is an example of a tumor originating from plasma cell. So these are the various tumors which are associated with the development of B cells. What about the T cells? Well, for the T cells, first we have the CD4 and CD8 positive lymphoblasts. These are actually the T lymphoblasts. So the T lymphoblast will give rise to what? So far what have we discussed? We have discussed about T acute lymphoblastic leukemia. That is TALL develops from the immature T cells, whereas the peripheral T cells, they give rise to peripheral T cell leukemia or lymphoma. These are the tumors which are associated with the B and T cells. Once again, to brush it up, we have the lymphoblasts giving rise to lymphoblastic leukemia. We have the naive B cells or giving rise to chronic lymphocytic leukemia. We have the germinal cell B cells giving rise to Burkitt's leukemia and Hodgkin's lymphoma. We have the plasma cells giving rise to multiple myeloma. When it comes to the T cell, the T lymphoblasts give rise to lymphoblastic leukemia, whereas the mature T cells give rise to peripheral T cell lymphoma. So that's about it. Now we move on to the WHO classification of acute lymphoblastic leukemia. So it's classified into BALL, that is involving the B cell, and TALL, which originates from the T lymphoblast. Now the BALL is again classified under two categories. One that is not otherwise specified, and the other one is BALL with recurrent genetic abnormalities. So this classification is based on the genes which are involved. We know that cancers are formed by recurrent by the mutations are what drive cancers, right? So depending upon which genes or a group of genes are affected, WHO classification is done. Now under the recurrent genetic abnormalities, the important genes which are involved are, first one is the translocation of 922, that is the Philadelphia chromosome. The next is translocation of 12 and 21. The third one is translocation of 5 and 14. Fourth one, translocation of 1 and 19. And the last two are hyperploidy, that is BALL with hyperploidy and BAL with hypoploidy. Now how do we remember this? Well, it's not so easy to remember. This is famous. This is a Philadelphia chromosome. This involves the Philadelphia chromosome, the first one. It's also involved in AML. So translocation of 921. And 1221, well, the numbers have just rearranged 1, 2 and 2, 1. That's how we can remember. The other two we can remember with the number 19. So 5 plus 14 is 19. And on the other hand, we have 1 and 19. So just remember roughly like that. There is no other way which I know of. And then we have hyperploidy and hypoploidy. So this is how the ALL is classified. Now moving on specifically into BALL, that is the lymphoblastic leukemia involving the B cells. So the cell of origin, they originate from precursor B cells. What are the pathogenesis? The genes that are commonly involved, that is there will be both translocation and numerical abnormalities. The genes that are usually involved are the RUNX1 gene and ETV6 gene. Those names are not very much important. Now coming to the clinical features. So they affect children. In fact, it is the most common malignancy of children. that is between 1 to 5 years. And there is an abrupt onset. The features of leukemia is presented within weeks to months. So onset is abrupt. Now what are the manifestations? The manifestations are mainly manifestations of bone marrow failure. So with bone marrow failure, what happens is that erythropoiesis is affected. When erythropoiesis is affected, we have anemia. What happens when myelopoiesis is affected? Well, we'll have decreased WBCs, and that will lead to infections. What happens when we have decreased platelets? The decreased platelets will lead to bleeding. So there will be bleeding disorders. Anemia will be manifested as fatigue or weakness. Now, why does the bone marrow undergo failure? The reason is simple. Because lymphoblasts will take over the space required for normal erythropoiesis, myelopoiesis, and megakaryopoiesis, and as a result, there is no space for the development of normal, mature RBCs, WBCs, or platelets. As a result, there will be signs of bone marrow failure, and there will also be associated bone marrow failure, which will present as bone pain and tenderness. Now coming to the TALL, the cell of origin, it is a precursor T cells. Now coming to the mutations involved are both chromosomal translocations and mutations in the Notch1 gene. It's common, it's not very important as I said earlier. Now coming to the clinical features. So it is presents the age. It usually affects the adolescent males. Adolescent males are predominantly involved, and the presentation is usually as thymic mass. There will be a mediastinal thymic mass. This mediastinal thymic mass may compress the large vessels and come with features of compression. And the other features include cervical lymphadenopathy, when the cervical nodes are involved. Then there is hepatosplenomegaly. And then signs, of course, of bone marrow failure, which will be present in both BALL and TALL. Now, how do we diagnose? So we begin, for all leukemias, as we can expect, we begin with peripheral blood and peripheral smear examination. In the peripheral blood, the RBCs and hemoglobin, as I have said earlier, normal erythropoiesis does not occur. So what happens is that the count of RBC count and hemoglobin is decreased severely, leading to anemia. Then about the platelets, as we can expect, that will also be decreased. What about the WBC count? The WBC count, because of the presence of blast, they will be very high, ranging from 20,000 to 200,000. The WBC count can go that high. What about the peripheral smear? In the RBCs, as it is expected, there will be an anemia. The anemia will be of normocytic, normochromic type. Normochromic anemia. What about the WBCs? The WBCs, there will be more than 20% lymphoblasts will be present. What are the features of lymphoblast as we have discussed earlier? Roughly, when we speak of it, it is 2 to 3 times size of a lymphocyte, having 1 to 2 nucleoli, and there is a blue basophilic cytoplasm. These are the features, and O rods are absent. So these are the features of the lymphoblast. What about the platelet count? We can expect there will be thrombocytopenia in the peripheral smear. Once the peripheral smear examination is done, then we move on to the bone marrow examination findings. What happens to the cellularity? We always begin with cellularity, and as we know, it could be hypercellular bone marrow. Erythropoiesis, of course, it will be decreased. Myelopoiesis will also be decreased. The megakaryopoiesis, all three will be decreased, and bone marrow will enter into a bone marrow failure. There will be failure of bone marrow. And the blast cells, or the lymphoblasts, they will constitute more than 20% of marrow cells, which is an important feature to diagnose. These two are important features, that is 25% of lymphoblasts and 20% of marrow cells. These are important features to diagnose, to confirm the diagnosis of acute leukemia. Now coming to immunophenotyping. So for B cells, they are positive for CD10 and CD19. CD10 and CD19, you have to remember these markers. And for T cells, they are positive for CD2, CD5, CD8. The presence of these markers gives us a clue about the type of cell. Cytochemistry, myeloperoxidase, we know it is present in the myeloblast, not in the lymphoblast. Therefore, myeloperoxidase will be absent or negative. It's not absent, it's negative. So myeloperoxidase will be negative. Sudan black as well, that is for monocyte precursors, that will be negative. And for PAS, there will be block positivity. What it means is that inside the cytoplasm, there will be blocks which are positive to PAS. That is what we mean by block positivity. The other findings would be, like in all leukemias, the uric acid level will be higher because due to the destruction of the leukemic cells during chemotherapy. And then LDH will be high because of the increased turnover of these leukemic cells. And we also do CSF examination. Now, why is CSF examination done? Because the TALL has a possibility for meningeal involvement. So to rule out the CNS involvement, we'll do a CSF examination. So that's one of the features which we actually missed to mention. Now coming to the prognosis. So finally, there are some features which indicate a good prognosis, while there are some other features which indicate a poor prognosis. So let's speak about factors which favor a good prognosis. First is the age. So age between 2 to 10 years. That's a factor for good prognosis. Whereas even a younger age before that, that is below 2 years, or older age, that is above 10 years. Both of these extremes of ages have a poor prognosis. When it comes to after age, the next factor is the sex factor. Females have a better prognosis compared to the males. And coming to the WBC count, as we can expect, a lower count means a more controllable tumor. So less than 100,000 cells per millimeter cube. Whereas more than 100,000 cells per millimeter cube indicates a poor prognosis. And the CNS involvement. So no CNS involvement, whereas positive CNS involvement indicates a poor prognosis. All of these are expected. And finally, about the genetic involvement. So in that, the Philadelphia chromosome, that is translocation of 922, gives a poor prognosis. And hypoploidy also gives a poor prognosis. Whereas hyperploidy, on the other hand, gives a good prognosis, and the other are the trisomy of 4, 7, and 10, and translocation 1221. These are the factors which are responsible for good prognosis. So once again, poor prognosis in the Philadelphia chromosome and hypoploidy, whereas hyperploidy and translocation 1221 gives good prognosis. Now trisomy, tri means 3. So we have 4, 4 plus 3, 7, 7 plus 3, 10. So trisomy of 4, 7 and 10 also gives a good prognosis. With that, we end this session on acute lymphoblastic leukemia. To summarize, acute lymphoblastic leukemia is the most common cancer involving the children, and it is a group of neoplasm that affects the lymphoblasts, which are the precursor immature B and T cells. And the diagnosis is through the peripheral smear finding and the bone marrow finding, which confirms the diagnosis, where there will be bone marrow failure with more than 20% lymphoblast in both peripheral blood and the bone marrow, or any one of them, which this will help to diagnose ALL. And the good factors for prognosis involves females between the age of 2 to 10 years having RBC count less than 100,000 cells per millimeter cube without CNS involvement, genetically hyperploidy and trisomy 4, 7, 10, and translocation of 12 with 21 indicates good prognosis.